Good morning to you all, respected chairpersons and my dear friends and colleagues. I thank the organizing team for giving me this opportunity. My talk is on myocardial infarction with the non-obstructed coronary arteries. So if you look at the spectrum of ischemic heart disease, you have the stable and unstable coronary syndromes. The stable coronary syndrome, you have the obstructive coronary artery disease, which leads to the stable angina, and you have ischemia with normal coronaries, what we call as the microvascular angina or the syndrome X. And the acute coronary syndromes, you have what we are familiar with is the STEMI and NSTEMI, and then there comes the MINOCA or the myocardial infarction with the normal coronary arteries. So it's a changing philosophy in that the non-obstructive coronary artery disease doesn't mean it's a false positive. It's not a false positive thing. The treadmill is positive or the troponin is positive, but the coronaries are normal. You cannot leave it at that. So we'll see in the subsequent slides. So this case of a 58-year-old lady who came with acute chest pain, sweating. The ECG shows ST elevations in the anterior leads. Subsequent ECG after a half an hour, it shows some evolution of the changes, terminal T inversions. So in view of symptoms, she is taken for emergency catheterization, and you see a normal coronary angiogram. But patient is hemodynamically unstable. She is in shock, initiated on vasopressor support, and IABP is inserted. And this is the left ventricular angiogram, which shows only the basal segments are contracting. The rest of the LV is ballooned out, typically what we see in the Takotsubo cardiomyopathy. So a subsequently done MRI scan that reveals again in the apical and mid segments there is a lot of transmural edema. Transmural edema is seen in these segments while the basal segments are spared. So again this is the longitudinal axis. You can see the edema in the mid and apical segments, which does not fit in with any vascular territory. So it's a global change, not fitting with, even though the ECG was showing anterior wall changes. You are seeing this globally, and basal segments are spared. And so this is the echo of this patient on admission. You can see a picture very similar to the MRI where the distribution of edema was there, severe left ventricular dysfunction, and after about 72 hours you can see the improvement in the ventricular function. So here acute stress cardiomyopathy, reversible left ventricular systolic dysfunction, and there is no documented myocardial necrosis here by the MRI. And another case of a 55-year-old lady, again presenting with a typical anterior wall myocardial infarction. Troponin is elevated, but no significant coronary stenosis. Maybe there is some plaquing of the proximal LAD. LV angiogram is normal. So you have a picture of acute myocardial infarction, non-obstructive coronaries, and there is no definite wall motion abnormality here. And in the emergency room, a D-dimer is done. It is showing negative. Somebody suspects a pulmonary embolism. So that is also negative. So there is no apparent reason for this sort of presentation. So this basic 3 points which are important for the diagnosis of a myocardial infarction and normal coronaries. So this patient also gets a MRI, but here it shows that there is a subendocardial gadolinium enhancement, late gadolinium enhancement, which is suggestive of a definite myocardial infarction. So this patient has a necrosis which is confined to the LAD territory. So this is clearly a case of acute myocardial infarction, but the coronaries are normal in comparison with the previous case where there was no necrosis which was demonstrable in the MRI. So if you look at these two cases, so basically the myocardial infarction with the normal coronaries, it's just a working diagnosis. So you have to look into the basic etiology which is responsible for this. It is just like heart failure, diagnosis of heart failure, you have to investigate further for the underlying causes. So if you see, the normal coronaries is just a misnomer because intravascular imaging has shown that plaque rupture or ulceration that is located in a normal area of the vessel in about 45% of cases. So angiographically smooth coronary arteries is not something very reassuring. So here the intravascular ultrasound in fact shows a plaque rupture. And another important thing is what we are seeing is only about 5% of the total coronary tree in the angiogram, because the epicardial, the microvascular thing, which is a large microvascular vasculature, is something which we are not seeing in my coronary angiogram. So what we see is only the epicardial coronary arteries, and based on this we have said, we coined the term that it's non-obstructive coronary arteries, but the patient can have microvascular obstruction or spasm. So this can lead to this microvascular, classically it causes this slow flow phenomenon which we see. So the normal coronary arteries, but the microvasculature is obstructed, so that can lead to again one of the patterns of MINOCA. So basically the diagnostic criteria for MINOCA is that it's made immediately after an angiogram. So the patient presents with a typical, based on the universal definition of myocardial infarction, the patient fits in with the presentation of MI, that is chest pain, typical symptoms associated with the rise and fall of troponin values. So universal MI criteria, the patient presents with the features of MI, non-obstructive coronary arteries by angiogram, which is defined as a less than 50% stenosis of the epicardial coronary artery or a potential infarct-related artery, and no clinically overt specific cause for the acute presentation, like for example acute pulmonary embolism causing RV strain or sepsis or renal failure, which can cause this sort of troponin elevation. So there is no obvious other cause, but you have a non-obstructed coronary and a patient presenting clinically with chest pain and features of MI. So some of the features of this MI with the normal coronaries versus obstructive coronary artery disease, it's more prominent in female sex. They constitute about 50% of the MINOCA population versus 25% of the obstructive coronary artery disease population. And women with present with acute MI are twice more likely to have normal coronaries than men who present with myocardial infarction. And it is seen more often in younger age group, and very often you don't find the conventional risk factors in these cases. And 1/3 of patients, they present with STEMI, while the rest can present as NSTEMI. And most important to remember, it's not a benign diagnosis, and the outcomes, some of the studies have shown that 12-month mortality is similar with no significant difference in the p-value. And 5 to 15% of patients presenting with acute MI, both the groups, STEMI and NSTEMI combined, can have normal coronaries, epicardial coronaries. And they are likely to have, sometimes you may find very subtle ECG changes and much smaller degrees of troponin elevation than the obstructive coronary artery disease. And very often in the stress cardiomyopathy picture, we see that the troponin elevation is quite disproportionate to the degree of all motion abnormality that you see. So this again to show that the mortality in hospital as well as 12-month mortality is quite high in the MINOCA population. So it is not a benign condition. So the etiology, if you see, you have the coronary causes, which can be coronary spasm or the microvascular problems due to which can lead to coronary slow flow, microvascular spasm, coronary plaque disruption, most important, like the plaque erosion or a plaque rupture, or dissections, spontaneous coronary artery dissections, which are not sometimes seen in the coronary angiogram. Then coronary embolism or in situ thrombosis, sometimes in various thrombophilic situations, you can have in situ thrombosis within the coronary arteries, or embolism from elsewhere, you can have a patent foramina veil or a vegetation and things like that. And the missed obstructive CAD, which means sometimes you may see, if you don't look at the coronary angiogram in detail, you may find a smaller branch or a terminal branch which is occluded. So that is also very important that you should scrutinize the angiogram. So these are the most important, the coronary causes for the MINOCA. And then the non-coronary, the myocardial as well as non-cardiac causes. Myocardial causes, most important is the myocarditis, Takotsubo cardiomyopathy, and rarely in some of the other cardiomyopathies also. And non-cardiac, you have the, as I mentioned earlier, the pulmonary embolism, renal impairment, sepsis, and stroke due to excessive sympathetic discharge. You may find elevation of troponin and sometimes the wall motion abnormalities also. So this is the overall the etiology of MI and normal coronaries. So by definition, the coronary causes are is what is important for MINOCA. So when you say MINOCA, it is basically the you exclude all the others like the myocardial disorders and the non-cardiac causes, and then you come to this group, which is called as typically the MINOCA. So the potential mechanisms could be plaque disruption, vasospasm, dissection, thromboembolism of the coronaries, microvascular dysfunction, and sometimes even the supply-demand mismatch that we see with tachycardias, very fast tachycardias associated with hypotension. You may find troponin elevation. So again, a type 2 myocardial infarction. So that these are all some of the reasons for this sort of presentation. So this is from the American Heart Association, the traffic light sequence for the diagnosis of MINOCA. It's very easy to understand. Basically, the red constitutes the ruling out of MINOCA, and the green is where you have the high likelihood of a diagnosis. So when you have the typical myocardial infarction presentation, rise and fall of troponins, more than 99, at least one value more than 99 percentile, and associated with a less than 50% epicardial lesion. So you look at the clinical context. So look at other associated factors like sepsis, pulmonary embolism, any cardiac contusion. And then if that is there, then that rules out any need for further investigation. So once these are ruled out, you have the working diagnosis of myocardial infarction with the non-obstructive coronaries. So you scrutinize the angiogram better to look for any small branch occlusion, terminal, some embolic occlusion or a dissection, hazy areas in the angiogram. Or, and also you look for the other features of myocardial injury. So you can do an LV angiogram, rarely we do. Echocardiogram can be done to look for any wall motion abnormality that we typically see in the Takotsubo syndrome. And then MR imaging. So MRI has a very big role in the diagnosis of MINOCA. So with this you can have the diagnosis of obstructive CAD, coronary thrombus or embolism, the spontaneous coronary artery dissection, and Takotsubo syndrome and myocarditis. So these things can be diagnosed with the help of these three investigations. And then you come to the ischemic mechanism of, so once these are ruled out, you have the diagnosis of MINOCA, where again the MRI, as I showed in the second case, the MRI confirmed that the patient has an infarct even though the coronaries are normal. So that is the situation where you should suspect any, you should go for an intravascular imaging like IVUS and OCT to look for any plaque disruption or presence of dissection. And the functional assessment can be done once the initial acute phase is over and the patient is stabilized. You can go for a functional assessment to look at the microvascular pathology. And even FFR has been advised in these situations where to diagnose the microvascular function. So the workup of these cases, again, renal impairment, you can look from these routine investigations, we can identify most of these cases. Cardiomyopathy, again, echo and MRI. Yes, then suspected vasospastic angina, you can go for provocation testing. I don't know whether it is being done routinely in any of the centers. Microvascular angina, again, you can look for the, so one of the, as we see, it can manifest as slow flow, coronary slow flow, and you can make the measurement with the help of coronary flow reserve or TIMI frame count, and look for thrombophilias in those respective cases. CMR imaging, cardiac magnetic resonance, is the key investigation in identifying the underlying cause. So this case, you have a very minimal plaque in the left anterior descending artery, and you can see the late gadolinium enhancement in the LAD territory. This is the short axis and the long axis views, suggestive of a definite evidence of a distal LAD territory infarction. And with the help of MRI, you can make a wide range of diagnoses like confirming of MI as the previous case, myocarditis, stress cardiomyopathy, and other types of cardiomyopathies. And in about a quarter of cases, in case of MINOCA, you find normal myocardium also. And this is just another picture of cardiac MRI. Here you are seeing the subendo. In the case of myocarditis, you are seeing, this is a case of infarction with the subendocardial late gadolinium enhancement in comparison with more subepicardial enhancement that you see with myocarditis. So the location of the LGE is important in making a diagnosis of coronary artery disease versus myocarditis. And these are the vascular causes for MINOCA, as I mentioned: plaque disruption, coronary thromboembolism, vasospasm. So based on the diagnosis, intravascular imaging, you can pick up the plaque problems, and the treatment for these respective cases for plaque erosion or rupture, you give dual antiplatelet therapy and statin, while for thromboembolism, the respective anticoagulation. Spasm, if it is picked up, you can give nitrates and calcium channel blockers. And Takasubo syndrome, again, ACE inhibitors, ARB, and single antiplatelet is shown to be of benefit, and maybe some benefit for beta blockers also. Spontaneous coronary artery dissection, in the acute stage, you don't intervene, and again, treatment with single or dual antiplatelet therapy depending upon the presentation, and beta blockers. So basically, that is the treatment for coronary artery dissection. So this is just the flow chart which I have already mentioned, the diagnosis of MINOCA and the investigations that you should do, and then make the diagnosis based on MRI and other imaging. So the points to learn: myocardial infarction with non-obstructive coronary arteries, it's a heterogeneous working diagnosis, and it's not a final diagnosis. You have to rule out the various conditions and narrow down to the vascular causes, and requiring further investigation during and after the invasive angiography. So the diagnosis is made after an invasive angiography, and clinicians should consider the use of intracoronary imaging and physiology studies to assess the presence of any plaque pathology, microvascular dysfunction, and cardiac MRI with gadolinium contrast is recommended in the vast majority of cases. And MINOCA, it's not a benign condition, has comparable outcomes with obstructive coronary artery disease. And the treatment of the underlying cause is important, and very often it is empirical, based on extrapolation from the obstructive coronary artery disease data. Thank you.
Any role of trimetazidine?
Yeah, so I mean, trimetazidine, I'm not very sure, but microvascular dysfunction, there is some role for the nitrates are not of much use. So the ranolazine has been shown in some benefit for the microvascular dysfunction. The long-term treatment, well, that is for if it is a stress cardiomyopathy, often they recover completely. So myocarditis, it's depending on the specific condition. If it is a plaque rupture or erosion, it's like a treatment for coronary artery disease. So you continue with all the secondary prevention strategies.
That is a big question. When you say MINOCA, should you exclude all the other categories? Diagnose myocarditis, can you call it MINOCA? Because
so it is not, in the classic definition, it's not included as MINOCA. So,
excluding all other
yeah, that is what the traffic light, that diagram that was showing. So
only the green one would
so
be
only the
MINOCA.
green one will qualify for the MINOCA.
Any role for Nicaragua in these cases?
Yeah, I'm not aware of any different role for nicorandil. Well, for microvascular disease, all these have been tried.
I think in microvascular dysfunction, nitrates do not have much of a role, but there is some data telling that nicorandil could be useful, because nitrates generally dilate only those vessels which are more than 200 microns, whereas nicorandil can act even in smaller vessels. There is some data telling that it is useful.
But I think, before nicorandil, I think, or the first line of drug should be given. Nicorandil is always, and trimetazidine, nicorandil, all these come secondary, so.
Thank you so much, wonderful speakers, for the insightful and engaging presentation.